Ladies and gentlemen, I'm Eldanasoury, and I'm happy to participate with you in this virtual meeting. And I hope, inshallah, next time it will be a real meeting, because I really miss all of you. And I hope you're doing well, and you and your families are safe. And we hope to see an end to this pandemic very soon. I would like to thank Dr. Mohsen and his team for organizing this meeting, and for inviting me to share with you with my talk on posterior chamber phakic IOLs. I was asked to have a 20-minute talk to review the current status of the ICL. These are my financial disclosures. I'm consulting to Star Surgical with manufacturing the ICL. And to start, I'd like to start from the end, where today in 2020, we know that the posterior chamber phakic intraocular lenses are the winner. We had a long experience with the phakic lenses for the last 30 years, and there were lots of debates on what design is best, angle fixated, iris fixated, or posterior chamber. And today it's clear that the posterior chamber lenses are the winner for many reasons. Today, if you're going to talk about the posterior chamber lenses, I would like to measure the performance of the ICL against a set of criteria that can be the criteria for an ideal phakic IOL. So an ideal phakic IOL, though I know that nothing is ideal, but let's see how close are we from the ideal phakic IOL. So an ideal phakic IOL should be biocompatible, should be stable, predictable, preserves the quality of vision. The recovery after surgery should be very fast, and it should be easy to remove and exchange. And the lens has to have a safe and long back record. If an ICL, if a phakic IOL fulfills this criteria, I'll have no doubt that I can have it on my own eye or in the eyes of my loved ones. So let's start with the first criteria, which is the biocompatibility. There are two aspects of biocompatibility. Biocompatibility of the lens inside the eye, in terms of the risk that this lens impose to the intraocular structure. And the main intraocular structure that can be damaged by a phakic IOL are the endothelial loss, endothelial cells, the crystalline lens, the anterior chamber angle, and the iris. And by far, it has been proven over the years that the ICL is the least to induce damage to the corneal endothelium. The angle-supported lenses are more prone to induce endothelial decompensation, as shown in this slide that was presented by our dear friend, the late Joseph Collin, many years back, when he said that the typical presentation of a patient with angle-supported lenses is that he comes after many years of good vision, he comes complaining of transient steamy vision in the morning, and that was the start of endothelial decompensation. And that's why these lenses have been withdrawn from the market. The iris fixated lenses are less notorious to the endothelium. However, if the anterior chamber is not deep enough, or if the patient is rubbing his eye, or if the lens is not well fixated in the anterior chamber, it might also induce corneal edema. And we studied the long-term effect of iris fixated lenses on the corneal endothelium, more than 90 eyes for more than 10 years. And the conclusion was that the anterior chamber depth from the endothelium, which is the aqueous depth, should be at least 3 millimeter in order to have long-term safety with this kind of lenses. Now, the second tissue that can be easily damaged by a phakic lens is the crystalline lens. And there are two possible causes: traumatic cataract, which is definitely related to the surgical technique, and metabolic cataract, which is more common, and this happens after a few months after the surgery. Surgical technique of the ICL should be very delicate. It's kind of fine surgery. It's an easy surgery, but it has the surgeon has to observe a few tips in order not to induce damage in the eye. The anterior chamber is filled with viscoelastic, but not overfilled, because overfilling the lens with the anterior chamber with the viscoelastic will lead to difficult unfolding of the lens. And then the lens is injected through a 2.7 or 2.8 millimeter incision. This is the wound-assisted injection. And then the main tip here is to wait till the leading haptics starts to unfold. Once the leading haptics are unfolded or starts to unfold, then you can inject the rest of the lens, and the lens will not go upside down. Upside down ICL is not fun, and if this happens, then it's easy to remove the lens from the anterior chamber and then reload it and put it again, in order not to induce damage by trying to flip the lens in the anterior chamber. Now, the metabolic cataract that can be induced by an ICL, all the cases of cataract that I saw after ICL, though there are very few cases, but in every case, there was a peripheral touch between the ICL and the crystalline lens. If you see this, this is the indication to remove an ICL. It's not only the shallow vault, but it's the peripheral touch, because here the aqueous becomes entrapped between the ICL and the crystalline lens, and this will lead to accumulation of metabolites and metabolic cataract later on. This peripheral touch is due to improper sizing of the lens. We're going to talk about this in a few minutes, especially when the lens has high power, because this means that the junction of the optic and the haptic are thick enough and to possibly touch the crystalline lens. Now, the second aspect of biocompatibility is the material. With the ICL, we are using the polymer material that has been used on millions of eyes for so many years, and it proved an excellent biocompatibility over the years. Now, there are few new posterior chamber IOLs. These are copies of the ICL, but with a different material, the hydrophilic acrylic. And we're going to see in the next few years how compatible is this material inside the eye. So the main strength of the ICL is the material. It's exclusive to Star Surgical. The polymer induces less dysphotopsia than the acrylic. Inflammatory reaction is very low, and it has a proven history over the years. With the polymer, it was proven by electron microscopy that very few protein deposits are found on the polymer after implantation inside the eye, as compared to the acrylic, as you see on the left-hand side here. Also the polymer, after you put the ICL inside the eye, it becomes coated with a layer of fibronectin, which is naturally occurring inside the eye, and this decreases or inhibits the inflammatory response. That's why the eye is very quiet from the first day after surgery. With the new models of the ICL that has the central hole, the V4C and the EVO and EVO Plus, the aqueous flow is more or less physiological because it goes through the center, through the central hole, through the pupil to the trabecular meshwork. So when we stop doing peripheral iridectomies with the ICL, I think the rate of cataract decreased significantly. All the cases that I had in my practice with the ICL, very few cases, 4 cases in 1700 cases, and all had peripheral touch. All were with the V4B model before the central hole, and all these cases had phaco and trifocal IOL and are extremely happy. Since I started using the V4C and the EVO and EVO Plus that have the central hole, so far in more than 1,000 cases, I did not see any cataract. And I believe that the rate of cataract after ICL is very much reduced with this central hole. Now, the second criterion for ideal phakic IOL is the stability. And when we talk about stability, it's not the refractive stability, because any phakic IOL is has a refractive stability because it will not change the power inside the eye. But more important is the rotational stability. When you talk about toric lenses, the lens has to be stable and it should stay where you put it inside the eye. For many years, we were looking for the stability by using the internal optical path difference, measuring the toricity of the ICL inside the eye. Here you see the preoperatively and the post-operative, you can see the toricity of the lens inside the eye, and then 4 months after surgery and 1 year after surgery, and the lens is stable. So an ICL, a toric ICL, when it is properly sized, it does not rotate inside the eye. There is no late rotation of a toric ICL. A toric ICL can rotate inside the eye only if it is undersized. If you have a lens that is misaligned, this can be due to early rotation because of undersized ICL, or more commonly, at least in my hand, misalignment during surgery. And in this case, you will have the patient with mixed astigmatism, with a poor uncorrected visual acuity, and once you do the rotation and the alignment of the lens, the patient regains his uncorrected visual acuity, and it's usually a very simple procedure. And if the lens rotates again, this means that it is undersized. So this is something I learned over the years. If I have a misalignment, I rotate the lens back into the right position. If it rotates again, then this means that this lens needs to be exchanged. Today, with the modern digital way to align the axis, we can achieve much better alignment than before, than in the old days. And we can leave the patient at the end of the surgery with the lens properly aligned. The third criterion is the predictability of the lens. Again, the question is, for all phakic IOLs, the refractive outcome are excellent, should be really excellent. But the thing is, when do we start using toric lenses? Here it's a debatable issue, even internally in our hospital. Some surgeons were using toric ICL only with astigmatism above 2 diopters. Others are using with astigmatism above 1 diopter, and so on. So we did a retrospective study on more than 800 eyes, and we picked the eyes that had relatively low astigmatism, between 1 and 2 diopters, because this is the gray zone. Below 1 diopter, you can use a spheric lens. Above 2 diopter, you have to use a toric lens. But between 1 and 2 diopters, it might be a question whether to use a toric or spheric. And we looked at these patients, and they represented 26%, almost more than a quarter of these of our patients have a low amount of astigmatism. And we looked at this patient post-operative. And when we looked at the visual outcome for these patients, we found a significantly better uncorrected visual acuity with those patients who received a toric ICL. So we concluded that even if you have a small amount of cylinder between 1 and 2 diopter, it's always better to use a toric ICL. Now, if we talk a little bit about the ICL sizing, which is an unfinished business, the current status of sizing an ICL, the classical way to do ICL sizing is to use the white-to-white measurement, whether with a caliper or with a digital imaging system, and then to use the STAR online calculator to calculate both the power and the size. So here you need the white-to-white, the anterior chamber depth, the K readings, and the manifest refraction, and then the calculator will give you the suggested lens size and power. I'm still using this, and it's good for more than 95% of the cases. This is the volt that is measured after surgery. An ideal volt is somewhere between 300 and 400 or 450 microns. However, the acceptable volt is between 100 and 800 microns. And this is an advantage because the material of the lens is forgiving. So even if you have a shallow volt or a high volt to the higher side, it's not a big deal. You don't have to exchange the lens. But if you have a very high volt, like in this case, or a very shallow volt, like in this case, almost touching the lens, the crystalline lens in the center, then this is an indication for ICL exchange. In our practice, we measure the volt 1 month after 3 months after the surgery with the OCT, and this is the distribution of the volt achieved. The majority of the patients are between 300 and 600, but the whole cohort of these patients, of these eyes, 84 eyes, are between 200 and 900 volt. We looked at the correlation of the volt with different metrics. We found that the crystalline lens rise is very important metric that we are not still using in our classical way. So that's why we are working now on developing a formula that in our hands can give a better sizing. Our goal is to achieve an excellent volt between 300 and 450 in all our patients. So there is still room for improvement, though the current classical way to size the ICL is proved to be very safe and effective. There are many formulas coming, one from Nakamura, where he uses the anterior chamber width, which is scleral spur to scleral spur, measured by the OCT, and the crystalline lens rise. He's not measuring the anterior chamber depth in this in his formula. We tried the high frequency ultrasound to measure the sulcus to sulcus because we thought this will improve a lot our results, but unfortunately, after 2 years of using high frequency ultrasound and ultrasound by microscopy, we did not see an improvement in our results, and still we are at the range of 95%. And this technique is very demanding. It's technician dependent. It's cumbersome. It takes time, and the results are not reproducible. You have to use a water bath, and it's very complicated, and I wouldn't use it in a high volume practice. It's maybe only for research purposes. So today, the classical way to size an ICL is the white-to-white, whether caliper or digital imaging, and the anterior chamber depths with an OCT or Scheimpflug imaging. And this is good for the majority of the patients, as I said, 95%. There are other ways using the anterior chamber diameter, scleral spur to scleral spur, and the crystalline lens rise, and this needs an OCT. If you have a high frequency ultrasound, you can measure the sulcus to sulcus or the ciliary body inner diameter, which theoretically can give you good results. So to finish the sizing issue, what we are doing today is white-to-white diameter with digital imaging or caliper, and the anterior chamber depth, and then we use the STAR online calculator, and in our hands it's good for 95% of the cases or even more. Crystalline lens rise is an important factor that needs to be studied in more depth. Our rate of exchange in the early days with the older models was 5%. then it decreased to 1% when we started using the V4 model and the digital imaging. Nowadays, with the V4C, it's even less, like 0.6%, because even with, if you have a shallow vault with the central hole, there is no risk of developing cataract because of the aqueous circulation around the lens. The fourth criteria for an ideal phakic IOL is the quality of vision, the preservation of the quality of vision. And this is easy to understand because a posterior chamber lens is closer to the nodal point, so the functional optical zone is larger than anterior chamber lenses or even laser vision correction. Patients enjoy a very good quality of vision. Here we measured with the objective scatter index using the HD analyzer, and you can see the scatter index before the surgery and after the surgery is identical. So these patients did not lose any of their quality of vision. Comparing the ICL that you see here in the bottom to refractive lens exchange or phaco-emulsification and IOL for cataract patients, we found that the best quality of vision is achieved with the ICL. Those patients with clear lens extraction, whether you use a monofocal lens or trifocal lens or EDOF lens, there is a diminution of the quality of vision, which is reflected in increase of the objective scatter index. So this patient has decreased in the quality of vision. The cataract patient, because they already start with the cataract with a poor quality of vision, so they feel improvement, though their scatter is much higher than the clear lens extraction and the ICL. A fast recovery after phakic IOL is of course needed. With all foldable phakic lenses available today, we achieve very good results from day one after surgery because the wound is small, the lens is foldable, and it goes through a small incision. Most of these, the majority of these phakic lenses that we are using today are going to be removed maybe 20, 30, or 40 years down the road. So we have to keep this in mind. With the ICL removing, whether for exchange or for phaco IOL, if the patient develop senile cataract many years later, removing the lens is very easy through a 3mm incision. And again, this is because of the material of the lens is very flexible and very soft. The last thing that an ideal phakic IOL should have a safe and long back track record. This is available with the ICL. We have many studies showing the safety of the ICL after years. The worst case scenario is developing of anterior subcapsular cataract, which is less than 0.5% in our hands, and there is an easy solution for this. While other phakic IOLs have, if they have the worst case scenario, we go on endothelial cell decompensation, then you need more bigger and more dramatic solutions. So to conclude, the ICL today proved that the posterior chamber design is the best for phakic IOLs. The material already proved safety over many decades and millions of cases implanted. We have a very long back track record, and we have hundreds of peer-reviewed publications that make us feel very confident using the ICL for our patients. And I thank you for your kind attention.